لا دكتور اشرف، انا عامل موت.
على الفيسبوك.
انا عامل موت مش مفيش عندي صوت. انا هطلع خالص من البتاع.
طيب في ناس دخلت اهي. يزن حطر بيقول لك سلامي للجميع.
عامل لايف على الجروب بتاع الفيسبوك يا دكتور. خلاص
عمرو. عمرو كلم عمرو السيد.
اوكي.
سلام عليكم.
معانا الدكتور رامي النقيب كمان اهو، وسامي ركز من لبنان، وزكريا المير من السعوديه، ويزن الحطر من الاردن. نرحب بيكم جميعا. راح دكتور مازن عبد الله من فلسطين.
كريم،
دكتور مصطفى اتفضل.
احنا لما هنبتدي دلوقتي
دقيقة بالظبط.
انا بحاول اشير سكرين. هو مكتوب لي ان host disabled attendee screen sharing.
شير دلوقتي يا دكتور اتفضل.
اوكي. انا مفيش برزنتيشن في الانترودكشن، بس انت هتشفت الفيديوز في الانترودكشن، وبعدين هيبقى على الدكتور عبد الحكيم لمودريتنج ذا سيشن.
واي حد يقدر يعمل شيرنج دلوقتي يا دكتور مصطفى.
اوكي اتفضل. طيب احنا عايزين disable attendee annotations عشان في صورة حاجات في الخلفيات يعني، ودي
الصوت اللي في الخلفية ده من عند حد من الدكاترة.
لا
عشان كده بعد اذن كل واحد، كلنا اللي مش بيتكلم يديسيبل المايك بتاعه.
الصوت ده من ايه بقى؟
يعني
مفيش اي حد من اتنديز يقدر يشغل المايك بتاعه يا دكتور مصطفى.
الصوت ده من ايه؟
طيب
خالد حافظ.
خالد عمل
خالد مش معانا حتى.
خرج اساسا.
خالد مش معانا. هو الصوت راح دلوقتي.
لا برضه
يرجع تاني.
شكله دكتور هاني.
دكتور هاني.
ايوه
في صوت في الخلفيه عند حضرتك.
في صوت في الخلفيه. سامع عندي صوت في الخلفيه كده احسن.
بس يستمروا.
بيتعشوا. اعمل لهم اذا كان الناس بتتعشى. عندي ضيوف بيتعشوا زي بعض عشان خاطر اوكي يا جماعه سوري. كده الدنيا كويسه.
زي الفل.
تمام، احنا نقدر نبدا دكتور الساعه 9 دلوقتي، وفي 120 اتندي موجودين.
اتفضل يا مصطفى. كيك اوف يا مصطفى.
اوكي يا فندم. مساء الخير عليكم جميعا. بسم الله الرحمن الرحيم. On behalf of the Egyptian Society for Surgery of the Hand and Microsurgery and my colleagues Dr. Amr Sayed, أستاذ جراحة العظام and Professor of Orthopedic Surgery, Asyut University, Dr. Ashraf Muharram, Professor of Orthopedic Surgery, Cairo University, and myself. I'd like to announce at the beginning of our webinar today discussing the proximal humeral fractures. It's a case-based decision-making platform we will discuss with our distinguished panel, Dr. Abdul Hakim Abdullah, Professor of Orthopedic Surgery and Head of Orthopedic Department, Azhar University, and Dr. Hani Morsi, Professor of Orthopedic Surgery and Head of Orthopedic Department of Alexandria University, Professor Amr Ali Mustafa, Professor of Orthopedic Surgery, Ain Shams University, and Ahmed Fathi Sadiq, Professor of Orthopedic Surgery, Minya University. I'd like to welcome you all in this meeting discussing our cases. And I'd also like to acknowledge our industrial sponsors, MSD, and our organizing company, Continental Limited, for their effort making this webinar live today. And I'd like to thank Dr. Abdul Hakim Abdullah for moderating this session today. And I invite him to start the first session of this meeting.
Thank you. Thank you, Mustafa. I wish like to welcome you all, the speakers, panel, and attendee. We'll discuss today 4 or 5 different cases of proximal humerus fracture and their management. Every one of you are able to ask a question to the panel or to the speaker in question and answer column. Please write your questions and will be answered by one of the panels or by the speaker live. I would like Professor Ashraf Muharram to start the first case of this webinar. Professor Ashraf, please.
Thank you very much. I'm looking forward to this presentations. This will be an interactive session, so there are questions and live voting for the attendees. Please carry on with us. We're going to start with the first case. This is a 28-year-old healthy dentist who had a motor vehicle accident and suffered this isolated fracture. This is her CT. And this is our first question to the audience. What's your choice of treatment? Please vote. Okay. Karim will be able to see. We will be able to see the result. Okay, so 17 only decided to go for conservative treatment, 17 for closed reduction percutaneous spinning, while the rest of you voted to do an open reduction internal fixation. So let's ask our panel, what do you think, Professor Amr Ali, how would you treat this patient? What are the treatment options?
How are you, Professor Ashraf? I'd like to thank you for participating in this nice webinar with all of you, dear professors. If we look at this fracture, we have to think about two main items. First of all, the patient factors, that she is 28 years of age. She is a dentist, so she is cooperative, and 28 means that she has a good bone quality, high bone density. The second, we have to think about the fracture pattern. As we could see that the displacement in this fracture, it shows a little bit of, there is a varus malalignment. So this is first item. Second, that if we look at the posteromedial cortex or the medial calcar, we'll find comminution, but it's a little bit not so much comminution, it is a minimal comminution. So in such case, I think
this is posterolateral posteromedial comminution.
Posteromedial comminution. I think that, yeah, this small fragment. I think you can show it with the kerosene, sir. Yeah. And so I think conservative treatment is not an option. Why? Because if we leave it in such a virus, I think it will continue to progress. Because the virus stresses on the fracture will make it collapse more. For the second option, I think for closed reduction and percutaneous spinning, I think I may think about it, but in such case, I will enter intraoperatively. I should have the Phyllis plate beside me. In such a case that if I didn't obtain a strong, stable reduction with a good medial calcar support. I will tell the patient that I could try first, I will share with her the two possibilities, and I will try first to do really a closed reduction internal fixation, a closed reduction, sorry, and percutaneous spinning. The pros of this is that she has a good bone quality, and second, that she will be cooperative in the rehabilitation. But still, there is a possibility to convert it intraoperative into open reduction internal fixation if I didn't get a stable reduction.
That's really great. This was discussed with the patient, and she said she preferred not to have an incision and would prefer a minimally invasive treatment. And this what was done for her. Professor Amr, again, would you like to criticize this? Of course, the discussion with the patient would be to tell her that we will attempt closed reduction, and if we are able to achieve a decent reduction, we will probably can try to pin that. And a decent reduction means restoring neck shaft angle and posteromedial bony contact.
Yeah.
Do you mind to comment on this, Professor Amr?
Yeah, I will first comment on the reduction. I think the reduction is quite accepted. The neck shaft angle is reduced. Second, if we look at the medial calcar support, I think it has been regained. And I think the two wires that are placed in the posteromedial corner of what we call the inferior quadrant of the head, they are doing the same function of an helical screw. But I have some points against the method of fixation, really. First of all, the Kirchner wire that have been used, they are not threaded wires, which I think one of the main causes of loosening or that the pins will pack up once more again during the follow-up period. Second of all, I think there are too much pins that are not doing the main idea of pinning. First, I think it's better to pin in a biplanar, two different planes. Should be biplanar and should be at least perpendicular. So I recommend the two wires that are inserted just beneath the greater tuberosity to be inserted at the superior end of the greater tuberosity, aiming to the inferior aspect of the neck. Yeah, as you could show with the kerosene. beside these wires that are placed in the middle at the inferior aspect of the greater tuberosity, I think they are endangering the axillary nerve, which is normally present equidistant between the acromion and the deltoid tuberosity, as we can state between 5 up to 7 centimeters from the acromion. So it's a little bit dangerous.
So Professor Amr is saying that you are very close to the axillary nerve here, and that it should be in the distance between the acromion and deltoid tuberosity, which is mid part would be something like there, or 5 to 7 centimeters from the tip of the acromion, which would be exactly in this area. Okay. Okay. And as Professor Amr expected, this is what he was saying, that we should avoid the distance between 5 centimeters from the tip of the acromion and to 2 centimeters. This is where the axillary nerve is. The average is 5 to 0.6 to 7. This is the average distance. And the wire consideration should.
ممكن الصوت قطع، ممكن تعيد الكلمة دي تاني بس؟
Yes. Wire placement considerations, they should be well distributed and splayed. As you can see here, the whole head has wires in different directions. And so the splay and the distribution is quite important. The greater tuberosity should have been fixed better with the wire coming from anterosuperior to posterior inferior. So tuberosity fixation is important. You should avoid the axillary nerve, which is 5 to 7 centimeters from 5.3 centimeters to 7.0 centimeters from the tip of the acromion. And your best point of entry to achieve calcareous stability is 2x, which is the height of the greater tuberosity times 2. This is the point of entry for your screws for percutaneous fixation. One pin fell during the dressing, the dressing on the 21st day, and at 5 weeks, another 2 pins were found to be loose and removed, maybe because they were not threaded, as Amr was saying. And this is the final outcome, which is at 2 months, good bone union and good head, neck, shaft angle. In conclusion, closed reduction and percutaneous pinning can be used in 2-part surgical neck fracture, in valgus impacted fracture, 3 or 4-part fractures with good bone quality, minimal metaphyseal comminution, intact posteromedial calcar or reducible posteromedial calcar. And it's more, we should use it more in the younger patient with stronger bone quality and where complication and pin loosening is less of a problem, because pin migration is very common in this area, and literature has proved in multiple series like this study by Brian McGovern that it has a higher union rate, less avascular necrosis, less scarring, and better cosmesis. However, it's less biomechanically stable, and this can be improved by larger diameter pins, threaded pins, biplanar fixation configuration, and bicortical purchase of your greater tuberosities. So if good bone stock, K-wire fixation can be done, but reduction must be appropriate, especially the tubercles. Any comment from the panel?
May I ask you, Ashraf and Amr, one question? I have personally, I have problem with inserting the wires from distal to the proximal percutaneous. You find your wire slipped
Yes.
on the cortex. Do you have any surgical tips to avoid that?
Well, definitely it's a problem. You have to have sharp threaded pins. I like to use small chance screws, those like for metacarpals or something. If you have a sharp tip, they usually do not slide away. And the other thing is, you should, your point of entry, you could slightly make your hand more perpendicular to the point of entry for few drills till the tip of your pin rests on the cortex. I don't know, Amr, if you have any other tips to tell to the audience.
Yeah, I would like to do the same. To go, usually I make a snip in the soft tissue till the bone, and then I inserted it perpendicular, and then gradually I change the direction.
You enter distal to the deltoid porosity or proximal to the deltoid porosity?
No, usually I enter in the distal half of the deltoid.
Deltoid, yes. So it's above the T porosity.
Exactly. And if we go distal to the tuberosity, we are risking the radial nerve.
Yeah. If you have a bulky muscular man, sometimes you find difficulty inserting the wire through the muscle. Do you have any tips for that?
I think just spreading when you make a snip in the scan and the muscle, and the snip with blunted dissection till the bone, and then you go.
When you are doing pinning, you pin when the arm internally rotated, or you pin it with the arm in neutral position?
Usually I pin it in neutral, but after doing pins, we have to verify the position of the pins. So I think an important item is that you should fix till the subchondral bone. And so it's a little bit sometimes difficult to assess you are penetrating, violating the articular cartilage or not. So you have afterwards to make imaging in 4 different views: axillary, and internal rotation, and external rotation, and neutral.
Mustafa, please.
If you are going to splint the patient or in an pouch arm sling in internal rotation or resting position, usually if you pin the patient in a neutral position with the palm facing forward, and then you rotate the arm 90 degrees to rest the forearm on the chest in a pouch arm sling, usually the pins are tethered in the soft tissues, and probably I incline to apply the distal wires in internal rotation position and rotate the image to be perpendicular to the fracture site, and to get an auxiliary AP view during wire application.
I have some questions from the floor. When do you mobilize the shoulder?
Excuse me?
When you allow to mobilize the shoulder after pinning?
I start mobilizing after 2 weeks, okay? And gentle pendular exercises starting from the 2nd week.
Okay, and there is a question from Dr. Yazin. Aren't these pins painful?
Sorry?
Are these pins painful? Or well to related?
Not usually not painful.
Okay.
Usually not painful.
Mustafa?
Do we need to leave them for 6 weeks, or can we remove them just when the fracture is sticky? Do we need to wait till union, or it helps keeping the position, and then if the position is kept, union will be eventually guaranteed? I'm asking Dr. Ashraf and Dr. Amr.
It's a matter of personal judgment. It's a matter of personal judgment. I usually tell my patients when I do this technique that once the fracture is uniting, it will kick out the pins. So they would not be panicking when they find the pins on the bed. And at the same time, and as long as I'm seeing healing, I'm leaving the pins in till I'm sure, I'm confident that there is healing of the fracture.
Okay, can you proceed with the second case, please?
Yes, sure. This is another case, another 2-part fracture in a 54-year-old housewife after a motor vehicle accident with no comorbidities. and she goes to the OR next day. They attempt closed reduction. It's completely off-ended. So they proceed to open reduction, internal fixation. And this is her intraoperative reduction and fixation. Next question to all our 300 attendees. What do you think of this reduction? Is this reduction satisfactory? Please vote. Thank you, Karim. Okay, show us the result, Karim, please. Okay, 3/4 think it's not enough, and 1/4 thinks it's enough. Our next question would be, do you think this fixation is adequate or not? Sorry. Is this fixation satisfactory? Please vote. Okay. The result, Karim, please. Okay. So 2/3 C is inadequate fixation. Let's see what happens. So this is the X-ray 1 week post-operatively. There is significant failure of fixation here. Professor Hani Mursi, do you mind criticizing this fixation, and what would do you think made us reach this catastrophic failure in 1 week's time?
Okay, Ashraf, thank you so much. Can you hear me?
Yes.
Yes, sir.
Okay, then. Thank you so much for inviting me to this very interesting webinar. I think it's very stimulating for all of us, not only the panelists, but the audience as well. Well, I think this is, I'm glad that most of the audience has found out that the fixation is not adequate and is not stable. As you can see in the reduction of the fracture, there are some technical faults. Number one, you can see that the reduction has been done in various positions of the head. The most important is that the medial calcar, which depends, the fixation depends on for stability, as you can see, has been left shattered, and there is no medial calcar continuity. You can see that the Phyllis plate, which has been used, you can find out easily that the length of the screws and the trajectory is not as should be. They should be much longer. And by the way, this reminds me of two views. Whenever any of us is contemplating to do a Phyllis plate under C-arm control, there are two very essential views. One of them is what we call the plate view, which is not shown here, where you do internal rotation to find out that the head looks like an electric bulb, concentric with the shaft, and the plate is in the central part of the head. This is number one. And the other view, which is what we call the screw view, and the screw view, which is almost the view on the left side of your screen. This is usually done in external rotation of about 20 degrees so as to get away the effect of the retroversion of the head. And in this view, you should find out that the length of your screws should be long enough to go down to the subcortical bone, where most of the purchase can be achieved when you go down there. The other part is that if you can look at the lateral part of the metaphysis, you can see a big metaphyseal defect. And this metaphyseal defect is very important to be filled in, because this is a very important part of the instability of your construct. So I think the surgeon has missed many of those points, and this should be always in the back of our minds whenever trying to contemplate using a Philus plate.
Okay. I agree with all you said. I'm not sure about the varus and valgus reduction. To me, it doesn't look too. It might be in some varus as well.
Some varus,
but
because
definitely
you can see, and this comminution, it's quite clear here.
Yeah. We've got posteromedial comminution not reduced. We don't have any calcar screws going through the what we call the E screws. We'll show that well in our next slides. We have no calcar screws supporting the posteromedial cortex. We have nothing to fill the metaphyseal void, and the screws were too short. That's why most of you guys expected to have such a bad result.
And I think there's one of the participants raising out, as I said, the very importance, or the much importance of putting a graft to address the void in the lateral part of your construct, because this is very important biomechanically to keep the construct viable and stable.
Okay, what's a Philus plate? Philus is a proximal humerus locked osteotensis. It's anatomically pre-shaped, it's angularly stable, and it allows divergent and convergent screws, and there's a variable angle for direction of screws. You can see here that probably you've got your screws in different angles, varying from 90 degrees to 130 degrees. And most importantly, it does have these, what we call the E1 and 2 screws here that go through the calcar to support the posteromedial calcar of the neck. And these are very important screws to support the reduction. Also, Philus plates have these thin holes there. These two holes are made to hold the supraspinatus tendon, and these two holes the subscapularis, while the infraspinatus anterior spinal goes through these holes. We take sutures not through the bony tuberosities, but through the musculotendinous junctions, and we use those not only to manipulate the reduction, but also to fix them and tie them over the Philus plate, as Mustafa will be showing us. This is 5 weeks post surgery, and we would like to ask Professor Ahmed Fathi Sadiq, what's your plan of revision for this fracture now that this is completely off-ended? You can see the humeral head here and the screws there. Professor Ahmed Fathi?
Okay. Can you hear me, Professor Ashraf?
Yes, please. Come on.
Okay. Yes. First of all, I'd like to thank all the distinguished speakers and the panel for letting me participate in this event. Second, regarding this case, when you look to the final X-rays of this case, first I'd like to make sure that the viability of the head is okay. So I'd like to have more radiological workup to make the right decision, because of the viability is affected. So any further fixation will be if I have made sure that the viability is okay. Sorry.
We will discuss the viability of the head of the humerus will be discussed in Professor Mustafa Mahmoud's lecture, but I think it's viable, considered viable.
Okay. This head is viable, so I'll address all the points that were missed by the previous surgeon. So I'll use fixed angle, which gives me an angular and rotational stability. So I can use the phallus plate
دكتور احمد
after I make anatomical reduction or diminution or by strut.
connection is not clear يا دكتور احمد.
حضرتك سامعني دلوقتي؟
في حد تاني عنده مشكله في الصوت؟
يا دكتور مصطفى
اوكي
انا سامعه كويس.
اوكي
في مشكله عند الدكتور
حضرتك سامعني دلوقتي؟
كويس اوكي اتفضل.
حضرتك سامعني دلوقتي؟
اتفضل كويس اتفضل.
تمام. So I'll try to achieve anatomical reduction, then restoration or use a fixed angle plate, whether the phallus plate or the fixed angle condylar plate, trying to achieve strut grafting of the posteromedial comminution and the restoration of the medial calcar. And in such case of two-part fracture, we can use also an intramedullary fixation device with intramedullary nail or proximal nail. This will give option with a higher or superior biomechanical advantage.
دكتور احمد ممكن تغير الكونكشن بتاعت الانترنت تستخدم 4G او 4G بتاع الموبايل؟
اشرف كنت
اوكي.
يس اوكي. طيب
دكتور اشرف سامعني حضرتك ولا مش سامعني؟
زي الفل. This is what has been done. Okay. This is what has been done. This is a pediatric condylar blade plate. It's not commonly used anyway nowadays, but it takes 4.5 screws, and they apply the condylar blade plate, and it's very clear that they applied a compression device here to compress the fracture and put these screws in. And this is after 4.5 months with union. Would you like to comment on the revision, Professor Ahmed Fathi?
Okay, this is what I was talking about. The revision is excellent. The proximal screw of the condylar plate is targeting the calcar. I believe it's not so long, so it's not risking the axillary nerve. The angle, the neck shaft angle is okay. The healing is so I think this solution addressed all the problems in surgery.
Yeah, this screw is commonly forgotten because with this excitement of reducing and fixing by screws, you forget to remove this compression, the screw which you put the compression device on. Anyway, that's the end of this case, and now I call on my colleague. You have comment for the floor? Please.
We have plenty questions from the floor.
Please.
Okay. If you don't have this plate, how to fix it with how to reduce it and fix it with the phallus?
You can, but it will be not an easy task, but you can. But using the technique Mustafa Mahmoud will highlight in his next coming case, in which you put a huge graft intramedullary, and this graft intramedullary would prevent further collapse from the head, and you put it in a compression mode after you fix the humeral head in valgus position. You can use a phallus plate again, but it will not be an easy task.
These are questions in the first X-ray. If you have a gap like this in fixation,
Yes.
Do you have to put graft?
Yes. You have to, if you go back to this slide, you have to make sure that you don't leave such a big gap. You have to try to reduce this. If you cannot, you have to put a graft in this area. Probably a non-collapsible graft, corticocancellous graft.
What is the usual X-ray view that you take when you put a fillers plate?
To check the height, okay? To check the height, you have to see a dead lateral view in which you would see the plate in the as we can see it here, dead lateral. You don't see the holes. You see it as in a lateral view. This will give you a good check about the length of the screws and the height of the plate. However, I personally do, because we've got divergence in the screws and convergence, so to make sure I do 30 degrees internal rotation, 30 degrees external rotation in this lateral view to check the penetration of the screw. However, it's quite important once you've done your preliminary reduction to try to take a lateral view better than this one. You should try with the image intensifier coming from above the head of the patient to take a view in which you can see the plate end on, because you need to see a dead lateral view, a dead axillary view, if you want to call it, because you need to see what we call the lollipop on the stick. What does the lollipop on the stick means? Means that the shaft should be exactly aligned under this humeral head. Okay? So these are the 4 views I take. I take a lateral view, 30 degrees internal rotation, 30 degrees external rotation, and after I put my first screw in the shaft, I try to take a lateral view of the head. An anteroposterior view of the head.
Is it possible to put a medial plate? And what's its complication?
First of all, let's go back to this slide. Okay. The Philus plate is designed so that the anterior edge is just behind the bicipital tuberosity. Your plate should be 8 millimeters, 1 to 1.2 centimeters from the tip of the greater tuberosity, and the anterior edge should be just behind the bicipital groove. Okay, and this is the preferred place, so it's on the lateral cortex. Sometimes when there is severe comminution, or you've got an anterior or you've got a huge gap, or you've got very small purchase of the head, you can put an anterior plate, not a posterior plate. You cannot put a posterior plate because the axillary nerve will be in a huge amount of risk. You can go just in front of the bicipital groove. There is the lesser tuberosity. You can put a contoured 3.5 millimeter small recon plate, locked or normal. But you cannot put a posterior plate.
An axillary view intraoperative is most important view to have, and you answered this point. So I think we answered all questions. There is one asking on how to Mustafa Mahmoud, how to reduce the fracture closed. I may ask Mustafa to answer in his talk. There's a question from Dr. Saeed Al-Sani. You can use direct lateral approach. When you use direct lateral approach, Ashraf and Hani and
in a 2-part fracture or a 3-part fracture with big fragments, you could easily use a transdeltoid direct lateral approach, and it is recommended because it is it's a relatively NEPO approach, minimally invasive approach, and it's you can control your fracture and reduce it. However, in the presence of 4-part fracture or comminution, or if there's a possibility it arises to use a graft, you better use the electoral approach, which is a more extensile and the formal doorway to the shoulder.
I think the lateral approach is very nice and handy approach, but as Ashraf said, it's a limited approach, and in most of the cases, you would like to have a look at your axillary nerve, which, as other speakers have said, it's about 5 to 6 centimeters down from the acromion. And I personally, I would like to see the nerve. Sometimes I tag it to get it, or in many cases, I tag it to get out of harm's way. So the lateral approach is a handy approach, but it's a very limited, and it needs only a very minimally displaced fracture because you don't have ground for manipulation. So yes, there is a place for it, but it's limited, really limited.
Same for me, Professor Hakim.
Dr. Saeed, we comment, and you can see the nerve and protect it. Do you usually explore the axillary nerve when you're doing proximal humerus fracture?
No, you don't. You don't explore it.
Any one of the panel explores the
yes,
video?
I do that. I usually have to have a look at the nerve. I have to have a feel of the nerve because at the end of the day, you don't want to destroy the whole construct by having an axillary nerve injury. And I think this is recommended in many of the textbooks. You have at least to have a mental feel and palpation of the nerve if you don't want to safeguard it and take it away out of harm's way.
دكتور حكيم
اتفضل.
أول حاجة أنا عندي سؤال دكتور أشرف. If you have a gap في ال primary fixation like في أول X-ray عملتها, instead of you are putting a graft, may you compress this gap?
Yes, definitely. This is a very viable option, especially if the gap is not very big. What Professor Ahmed is saying is that you probably can put some compression here, and this will take the shaft up and will do a secondary post-remedial stability of the fracture.
Okay, I have two other comments. The condylar plate you showed, I know it was commercially in the past, but now if you want to do it, or anybody can do it using a small DCB, ordinary small DCB, and you contour it, and you put a transverse limb to act as a blade. The second thing concerning the axillary nerve exploration, actually, you should explore it when you do a direct lateral approach. You should see it at least in the end of in the distal part of your incision to protect it and slide the plate underneath it. But in deltopectoral approach, you don't have to explore it. Of course, you can palpate it in the inferior edge of the subscap. To be sure of its place, and it's very important to put your Hohmann retractor just proximal to the deltoid tuberosity in order to stay away or distal to the axillary nerve. If you put it close to the head, probably you may danger the axillary nerve. And that's my comments.
Okay, thank you, Professor Ahmed. This was really useful. Now I'd like to leave the floor to...
I may ask the panel just to help me in answering the questions.
Please.
Okay. Anyone is not presenting or discussing the case, just review the questions in the question and answer. And I wish to ask the participants, just write your questions in the questions and answer section, not on the chat section, please. Dr. Mustafa Mahmoud, would you please share your screen?
Yes, sure.
By the way, we're now over 350 participants. Thank you, everybody, for sticking around.
Yeah.
Thank you very much for the very interesting two cases. In this patient with a valgus impaction fracture of his left shoulder, he's a 61-year-old male with a dominant arm affection due to fallen outstretched hand. This patient has a valgus impaction fracture of the left shoulder, and in this patient, we would like to follow the strict biomechanical rules to avoid the complications discussed by Dr. Ashraf Muharram and our panel. And I'd like to ask Dr. Abdul Hakim Abdullah, what do you think the classification? What's the classification that you usually use in these patients? Dr. Abdul Hakim.
Hakim is not there.
Dr. Hani, you're with me. Can you comment on?
I'm with you here. Yeah. Yes, Mustafa. Actually, I follow the classification. As everybody knows, there are lots of classifications, AO and other classifications. I think they are very complicated for me. So this is obviously a four-part fracture. And this is an easy classification. You have the four components: the tuberosities, the head piece, and the shaft. So this is a four-part new classification type.
Do you use one of these classifications, AO or a Lego classification, Dr. Abdul Hakim?
I think I don't like to use a single classification. Sometimes when you say it's four-part fracture, it's to give you that this is a bad injury. But when you are using the Lego classification or the AO classification, it gives you something that what you should do in the surgery and what is the prognosis. So when you use the logo system, you decided where is your head, where is your tuberosity, lesser and greater tuberosity, and where is the shaft. So you decided the surgical technique and how to fix from spreading the four parts. And also the AO classification give you some regarding the prognosis of the fractures. And so you cannot depend on one classification in treating of these injuries.
Okay. Do we need further investigations, Dr. Hani, for these patients?
Yeah, for such horrendously comminuted fracture, of course, you need a CT scanning and. Okay, so you have the answer beforehand. Yeah, I think with 3D reconstruction, because this is very important to have 3D information about what type of fracture are you going to deal with, and what's the best way of fixing all these comminution together.
Mustafa, I would like to see these two views especially. Would you go back, please? Mustafa, would you go?
Yes.
Yes. I like to see the axial view, this axial view, because this will show you the head split, and the sagittal view or the coronal view, it shows you.
Here?
Yeah, this is the view where you can see the articular split, and for the other view, it gives you impressions. Where is the tuberosity, and I may use my.
So this is where we see the sagittal split.
Yeah,
and here is the anatomical neck.
Here you see this is the articular surface, and this is the tuberosity. And the intraoperative, you cannot see this area because the tuberosity are hiding, and the articular mass is in valgus, and the tuberosity covering the articular surface. So you have to go between the tuberosity just to reduce this segment. Unless if you fix here, you will fix it in valgus impaction.
Okay.
It's important to recognize this area intraoperative just to correct it.
So we can predict that when reducing this anatomical head fragment in its position, and we will have a metaphyseal defect here that we need to fill to prevent the head from falling down into valgus again or any malposition.
Of course.
Okay. And then the 3D CT is not adding much in this patient. I agree with Dr. Hani that it in many cases it's very helpful, and but
Mustafa, but if you see this view,
yeah,
do you see my cursor? You will find the articular mass, the articular cartilage is inside the two tuberosities.
Yes, this is the greater and lesser.
Yeah. So
and this is the
intraoperative, and the muscle usually is covering this area. So intraoperatively, you have to go inside this area to correct the valgus impacted head.
Okay. Dr. Hani, what's the treatment option for this patient, and what are the risks, and what are the mechanical challenges in these fractures subject to?
Right. You told me how old is your patient?
61.
He's 61. Okay. You can see quite clear that, as you mentioned here on the screen, the risk of AVN is obvious, especially that the head portion or the articular portion is very short with no metaphyseal connection. Mechanically speaking, there's a lot of comminution and a lot of instability. There is a metaphyseal void which you have to address and fill in. You have both your tuberosities pulled by their attached cuff tendons. You have the biceps tendon in the middle of the two tuberosities and pressing them apart from each other. You have to look for, if you're intending to do internal fixation, you have to look, I repeat, you have to look for your axillary nerve, see where it lies, and have to safeguard it by all means, of course. The question here is whether you're going to follow the option of arthroplasty in this age group with the complications that you are anticipated if you're going to internally fix, or if you want to keep the anatomy and do it in a proper way, you can go on with properly fixing you and doing a very stable construct.
Okay. So in this patient, we need to know the background of the vascular supply of the head, because in this patient there is the medial metaphyseal extension of the head, which is in this area. It's very small in our patient, and if it is less than 8 millimeters, it's very subject to AVN. Also, loss of medial hinge according to Hurtels in these valgus impaction fractures will lead to disruption of the blood supply. And if the medial metaphyseal extension is less than 8 millimeters, the head fragment is avascular in 84% of the patients. And if there is loss of medial hinge more than 2 millimeters, the ischemia is 79%. If you have both loss of medial metaphyseal extent and loss of medial hinge, the incidence of ischemia is very, very high. It's 97%. And this is because the blood supply of the head is usually, it was known as the main blood supply to the head is the anterior circumflex humeral artery. However, it's believed nowadays that the main supply is the posterior circumflex humeral, and if you have a comminution in this fragment, as I'm pointing, it leads to disruption of the blood supply to the head. And if this anatomical neck, as in our patient, is falling into valgus, and the medial hinge is lost, it also disrupts the blood supply. But the question is, in nearly all 3 parts and 4 parts fractures of the proximal humerus, the anterior circumflex humeral artery is disrupted, and the posterior circumflex humeral artery is disrupted in patients with small metaphyseal extent and large medial hinge. But I think in the incidence of avascular necrosis in these patients after fixation is not as high as what's reported by these anatomical studies. And we have a tendency to fix these patients and to follow the strict mechanical rules to help creating a stable construct, because if the head is already avascular, you give it a chance to revascularize. And we aim at osteosynthesis of these patients to give the chance to the natural biology of revascularization and creeping substitution to replace even the avascular parts of the head. So in these patients specifically, the proximal humerus is subject to varus malalignment that we usually need to support the posteromedial part. We add intramedullary graft, and to avoid the tension of the lateral side of the head, by closing the tuberosities together, by rotating, by repairing the rotators to the plate, by creating a tension-free construct in the proximal humerus that we allow some subsidence of the neck over the shaft, as Dr. Amr said, suggested. And this subsidence will help create a tension-free proximal construct that is anatomically sound to give a chance for revascularization, even if the construct has an ischemic head. So we chose to approach these patients using the deltopectoral approach. This is distal, this is proximal, and this is the head fragment between the 2 tuberosities. You will see here, this is the lesser tuberosity with an ethibond suturing of the subscapularis, and this is the upper part of the greater tuberosity with suspension of the supraspinatus, and in the back we suspended the teres minor and part of the infraspinatus. And in this patient, we reduce the anatomical part of the head by, yes.
This is a question to show the valgus impaction. Would you show it how the articular surface impacted?
It's here, as you see, if we, this is the articular surface, and when we rotate the articular surface, it reduces to its position, and we perform traction on the shaft and pushing the articular surface to its place. We manipulate the medial metaphyseal comminution without stripping of the periosteum over it to guarantee the best biological environment for revascularization of the head. And after reduction of the head, there is a void here, and you'll see the greater and lesser tuberosities are closed together and will be tied together under and over the plate. We manipulate the medial comminution to allow the best achievable reduction without the need for anatomical reduction of the medial comminution, because we allow some subsidence. And as you see here, there is a defect inside the head, and this defect, if left unfilled, the articular fragment might fall into valgus again, and if it's in varus position, it might fall into varus, as I'll show you in the second case. We usually use a strut graft from the iliac crest, tricortical graft from the iliac crest. Many prefer to use fibular graft. However, we have a preference of using the iliac crest graft because it's curved, and we use it to be pushed against the proximal part of the head. And as you see here, we impact part of the graft into the medulla, and then we push the proximal part of the graft against the head to support it. And this is the final construct with this opaque shadow of the iliac crest that is supporting the head, preventing its valgus malposition. And then we approximate the tuberosities together and suture the greater tuberosities to each other. Then we apply the plate, passing the sutures of the rotators to the small holes of the plate. Apply the distal screw first, and preserving the height of the plate, not to prevent further impaction later on, and apply the first screw proximally without drilling of the graft to push it as much medial as possible to support the head, and then apply the other screws. So we allow subsidence. We try to apply posteromedial screw in this area because it helps supporting the head from falling into varus. And this is the final construct with the plate applied just behind the bicipital tuberosity, and the rotators are sutured under the plate, and in the holes of the plate, preservation of the soft tissues on the medial side without reduction. We just feel the reduction of the medial side. And you'll see here the construct is fixed by two posteromedial calcar screws, and this is not anatomical reduction of the posteromedial surface, but there is some subsidence because it allows a tension-free construct of the proximal shaft. And also in this example, you will see here the final consolidation of the iliac crest graft supporting the head fragment, and healing of the posteromedial comminution with no loss of reduction, maintenance of the neck shaft angle, and no varus or valgus. We usually need to keep the final configuration of the fixation like this. The plate is not high. The posteromedial calcar screws supporting the head fragment. The head is prevented from falling into varus or valgus by the screw or by the graft, and the whole construct will maintain an intact structure to for this head fragment to revascularize and to consolidate. And in this condition, we recommend very much using intramedullary grafts in comminuted proximal humeral fractures because it helps achieving the best mechanical advantage of using the Phyllis plates. So In conclusion, we recommend suturing the rotators, closure of the tuberosities to each other, relaxed tension allowing some bone subsidence, posteromedial buttress by structural bone graft, either iliac crust, fibular graft, or even synthetic grafts. And we suggest too much intramedullary support because it is impacted in the distal fragment and in the proximal fragment in the same time. And the take-home message is we strongly recommend using an intramedullary graft.
Thank you very much.
Thank
Dr.
you, Mustafa.
Thank you for this very marvelous operation. And I think we need to point out the secrets of success in such very difficult cases. Because as you pointed out, number one, you have to fiddle the least possible with the soft tissues to keep the blood supply of the articular surface. It's very important because you are having behind your mind that AVN can happen anytime. So you increase the likelihood of the survival of your head with keeping the blood supply and not playing with the articular segment, as you've said. Medial calcar stability is very, very important. You put your calcar screws to keep the posteromedial comminution. Importantly, putting your graft. I think this is very, very important, as you have pointed out. Now, you pointed out that some people put a head of a fibula. I personally don't like a head of the fibula because, number one, the volume is not usually enough to fill in for the void. And number two, it's mainly cortical, and you need your iliac graft for maximizing your osseointegration. So I quite agree with you. The best, I think, is the iliac bone graft. As you said, bringing back together the tuberosities is very important for stability and even for blood supply, because they have a very nice blood supply through the cuff, and they are very important for the viability and the vascularity of your construct. I have one point to raise, one point which is a bit controversial. I think it's very important to mention, which is the deforming effect of the biceps tendon. Sometimes when you're dealing with, especially when you're dealing with osteoporotic bone, the biceps tendon is a deforming force. And sometimes you can resort to doing a tenotomy of your biceps. And I don't know whether the other members of the panel do this. I sometimes do tenotomy of the biceps tendon, and I fix it to the tendon of the pectoralis. This is very important. You keep the function of the biceps very well. You don't have any propies or whatever. And at the same time, you eliminate the deforming force of the biceps. So I would like to know your view, Mustafa, and other panelists about this point in particular.
I think I'm aware of some studies comparing doing a biceps tenotomy or tenodesis at the time of fixation or arthroplasty fixation, and they report less pain, less post-operative pain, and better range of motion doing biceps tenotomy or tenodesis, as you mentioned, Dr. Haney. But I usually do it if the sutures of the rotators are compressing the biceps tendon, or I don't know if there is any problem passing the sutures of the subscapularis to the plate, or constricting the biceps tendon passage in its groove. But I'm not used to do it routinely. I don't know why, but probably I'm considering doing this.
I only release it in old age when I find degenerative. In young adults, I don't usually release it.
Okay.
My experience is a bit different from your guys. I always try to preserve it, and every time at the end of the surgery, I find that it's not gliding well with the plate and screws. It's very difficult. I tend to do biceps tenodesis as a standard procedure of my in my surgery. I release the biceps from closest to its origin from the glenoid, and I tenodese it to the pec major muscle before I leave. And I tried so many times to preserve it, but at the end of the day, I've never been satisfied with its position post-operative.
So it seems it's a controversial issue, but we have to keep it in mind because it could be deforming force, as Ashraf said, it could be a bit unhealthy. And you just keep it in mind. Sometimes we have to do it.
Mustafa.
Yes.
May I summarize your point as I understand, and you correct me if I am wrong?
Yes, please.
You have a problem of condyles, of tuberosities. So you have to take sutures in each tuberosity to close them together.
Okay.
You have valgus impacted articular mass, and this valgus impaction cause comminution. So you have to reduce this articular mass and support it with the graft, and then you do some traction on the shaft just to keep it, to bring a room for the tuberosity to be closed.
Okay. Yes.
Is that correct?
Exactly correct. And then I'll add a bit of information, preserving the vascularity by not trying to reduce the posteromedial comminution, but just supporting it from inside the open window of the tuberosities.
Okay. This is a matter of too many questions from our colleague participants. They're asking how you predict vascularity and how you keep vascularity and how to be away from the axillary nerve.
In these patients, and I don't explore the axillary nerve. I never have to, and the vascularity.
Do you release the distal insertion of the deltoid?
Sometimes, yes.
Yes.
Because I don't want to do much tension on the deltoid.
Yeah.
Regarding the vascularity, there's many ways to assess if this head fragment is vascular or not. But consider it.
We'll come to this with the talk
with Dr. Ashraf, yes. Okay.
So, but I think he wants to say whatever it's vascular or not, in young adult we have to fix.
Yes, because the incidence of avascular necrosis in the lab studies or cadaver studies or perfusion cadaveric studies, the incidence of ischemia of the head is much higher than what we find clinically after fixing these patients. Probably the answer for this question is the creeping substitution and the revascularization that happens to the neck, but you need to the head fragment, but you need to keep the construct stable enough to give it time to revascularize. That might take more than 6 months to 1 year.
Yeah. I think we are running short of time. Mustafa, may I ask you just to go to the question and question section and answer some of the questions of the audience, please?
Yes, please.
Okay. Dr. Ashraf, would you please share your screen?
Yes, sir. It's shared. You see it?
Yes, please. Go on.
Okay. Going on to the next case. This is a 70-year-old female who had a 4-part fracture dislocation of her shoulder. Okay. And this is her humeral head, and this is the glenoid, of course. This is her lesser tuberosity, and this is her greater tuberosity. So it's a 4-part fracture case like Mustafa's case. And the question to the audience is, do you fix this or do you replace it? Please start voting now. Kareem, can you please put on the voting panel?
دكتور أشرف ثانية واحدة بعد إذنك.
على مهلك. Sorry guys, take a bit of a technical issue.
So it is 70 years old, 4-part fractures.
Yes, let's take a look back at the X-ray by Mustafa's way. So my first question to you, you fix that or you replace it? Okay. Okay, are we ready, Kareem? Any questions in the panel you can answer while Kareem is getting ready?
There's some comments from on the chat section. Some colleagues say considering her level of activity and need.
She's 70 years old. She is a nice grandmother who cooks her own food and goes for limited shopping outside her house once or twice weekly, and goes and visits relatives and friends once or twice weekly.
Six rows.
Okay.
5 replaced and one fixed.
Please, Kareem, put the question up. Okay. You fix the fracture, or do you replace the humeral head? Please vote now. Okay, can we see the result, Kareem? Okay, 74% said replace. They don't like your technique and stuff. Okay, let's see next what happens.
Before they talk of Mustafa, there will be 100% replacement.
Okay.
So okay. Mustafa succeed to convince 27% to fix.
That's good. Good. Okay. Is this humeral head avascular? This is my next question to the audience. Do you think this humeral head is avascular? Okay. Please vote. And when you have a result, Kareem, please show it off.
حضرتك ممكن تعرض السؤال.
كريم. Excuse me.
السؤال fix or replace برضه؟
لا السؤال اللي بعده يا كريم اللي هو is this humeral head avascular؟ آخر سؤال.
هو سؤال صعب يا أشرف من الإشاعة دي إن حد يقول whether it's avascular or not avascular، يعني بتصعب أنت علينا الأسئلة جامد بصراحة.
أشرف ممكن تظهر لي السؤال بعد إذنك لأن أنت بعت لي الأسئلة كده، فبعد إذنك ممكن تظهر لي.
أيوه السؤال الأخراني اللي هو ده is the humeral head avascular؟ Yes. اللي بعده.
قصدي حضرتك على السؤال ده يا دكتور؟
طيب معلش. Let's ask this question: is the humeral head avascular? Yes or no? please answer yes or no to avascularity of the humeral head. Okay. Can we see a result, Karim, please? Okay. Okay, 50% believe that it is vascularized and 43% believe it's not vascularized. Let's go back to the criteria. I will not repeat what Mustafa said and explained in his lecture, but we've got a very small metaphyseal part here, not a very big one.
Ashraf may lost connection. Ashraf lost connection.
أعتقد دكتور مصطفى.
Yeah, I think so. He's not in the gallery view.
So if we go back to Ashraf question, we find that this case has the criteria of what Dr. Mustafa said. This head is mostly avascular. In 70 years old lady, and 3/4 of our attendee are in favor of replacement. Dr. Mustafa, what do you think to start a case of Dr. Amr Said and unless Ashraf get connection back?
Okay. I think this is what suggestion, yes.
تاني الكيس بتاعتي
I'm back. Hello?
Ashraf is back.
Oh, I don't know how this happened.
Okay. Okay, continue your case, Ashraf.
Do you see my screen, or do you want to share it?
Not yet. Not yet.
Okay. Okay, one moment. Okay. Now you see it?
Yes, please.
Okay. The way to make sure that your head is vascularized is the most intraoperative accurate way is to do a 2.5 millimeter screw, put a suction on it, and start.
You mean drill?
You drill 2.5 millimeter drill bit. You put a suction on it, and you see active bleeding coming from the head. So intraoperatively, we found that this head was vascularized after reduction. What does literature say? In comparison between open reduction internal fixation humeral arthroplasty, Bestian and Hertel, who had a lot of impact on the shoulder surgery field in the last 20 years, discussed that open reduction internal fixation is advisable when adequate reduction and stable fixation conditions can be achieved, even if it was not vascularized, because creep substitution and revascularization can happen if we have adequate recreation and stability. While hemiarthroplasty is a viable alternative for patients with osteopenic bone or comminuted fractures in which we cannot achieve a good stable reduction. Perfusion is important, but it's not the only factor, because revascularization and creep substitution does happen. Fixation should be used if stable osteogenesis is only possible with good bone quality, integrity of the medial buttress, and reduction of the tuberosities is possible and amenable. So we went in, and this is our post-operative reduction. We put a Phillips plate in, and this is our situation. Is this reduction satisfactory? I'm going to ask this question to Karim. Can you put question 5 up? You think this reduction is satisfactory, guys? Please vote. Okay. Okay, most of you think it's a good reduction. Not happy about that. And my next question would be, did we expect this to happen? This is the picture 3 months down the line with loss of fixation. Professor Amr, would you mind telling us why this happened? And is this a satisfactory reduction and fixation for the proximal humerus? Professor Amr? Amr Ali?
عمرو مين؟
أنا قلت هيطوع فيك.
Okay. Yeah. I think it was not satisfactory. As Hertel have stated before, that we have 3 main things to be done in these fractures. First, to reduce the tuberosity. But if you look here in the post-operative radiography, especially the one on the right, you will see that the greater tuberosity hasn't been reduced at all.
Yes, for everybody to say, this is the greater tuberosity there. It's not under the plate. Okay.
Exactly. So this is first. Second, we didn't have a good medial support, as you can see here, medially. Third of all, I think there are much metaphyseal comminution. And so I think still there is a void in the middle, especially the void that is being left by not fixing the greater tuberosity.
Yeah. So probably, and he has an interferentry screw here from anterior to posterior, holding the lesser tuberosity. So probably he needed something like the graft, intramedullary graft, like Mustafa showed us in the cases before. So we should have expected this. Okay. Now we go in and we found that the head remnant to be very small. Okay. Professor Amr Said, what is the current management for this case? What do you think? What do we think we should be doing?
I think there is no place for to revise the internal fixation. You should go for arthroplasty. And in this case and in this age, the best option is reversed shoulder arthroplasty.
Okay.
Because in this old age, the rotator cuff probably will be not
Very
good
difficult.
condition. Tuberosity is off. Bone quality is not very good, so reverse shoulder is the best option for it.
Okay. So the problem with revision of, you want to add anything, Professor Amr Ali? Amr Mustafa? Professor Amr Mustafa, would you like to add anything? I think we lost him somewhere here. Anyway, this bone is too weak for revision fixation. The tuberosities are lost here, and this, if the tuberosities are destroyed, that means the rotator cuff is not functioning. Then we probably cannot do a total shoulder hemiarthroplasty, and we should go for a reverse shoulder replacement. This is the intraoperative picture for the remnant of the humeral head eaten out by the screws, and this is what we've done. This is reverse shoulder replacement. What's a reverse shoulder replacement? Reverse shoulder replacement is used to compensate for a deficient rotator cuff by loading the deltoid so it does not need the rotator cuff to force couple abduction and forward flexion. So by moving the center of rotation from here, from this distance to the deltoid, by increasing this distance of the center of rotation, then we get a more efficient deltoid lever arm, and we can compensate for a deficient rotator cuff. However, all these patients do have a deltoid atrophy. Any patient who had shoulder surgery or a painful shoulder even without surgery would have some deltoid wasting. And before we venture into the decision of doing a reverse shoulder replacement, we need to make sure the deltoid is functioning, and this can be done because deltoid axillary nerve injuries are common. It reported up to 56% of patients might have it. However, 95% recover spontaneously within 4 months, and being the most common injured nerve in proximal humeral fractures. The way we check the deltoid function is by palpation of active deltoid contraction. You put your hand on the deltoid and ask the patient to try to lift his arm, and you can feel a deltoid contraction. The second thing would be sensation of the upper lateral arm and an EMG nerve conduction study to detect nosogenic potentials is very useful as well. With a good deltoid function, you're going to expect a good initial function and great range of movement. However, you have to know it's a demanding procedure because you have to fully expose your glenoid, and it has some late problems with notching, wearing, loosening, deltoid failure. And one of the very important questions that have not been answered yet is that there are very limited revision options for a reverse shoulder replacement. Indication of reverse shoulder replacement in trauma is fresh fractures with absent or a deficient cuff, when open reduction internal fixation with lost tuberosities failed like this one, or failed hemiarthroplasty in a symptomatic patient are the indications of reverse shoulder replacement. Another question, when do you go for a hemiarthroplasty or reverse shoulder replacement? Professor Amr Ali?
I think I will go to reverse the total shoulder replacement.
Let's take the question from a basic standard point of view. If this was the patient initially, the first time you've seen the patient before the operation, would you have done a hemiarthroplasty or a reverse shoulder replacement?
I think when I will take the decision, I will go for internal fixation, and with reverse total shoulder replacement is present intraoperatively. So if I can't reach a good fixation, acceptable one, I could revert it directly to reverse total shoulder. Especially that this is an old patient. Most probably the rotator cuff are injured, because in the literature, cases above 60 years of age have about 30% associated rotator cuff injuries. And so in such cases, I think reversed shoulder will have a better function. And I think the literature is with reversed total shoulder in place of hemiarthroplasty. And patients with hemiarthroplasty are less satisfied than those with reversed total shoulder.
Okay, you're completely right. This is a blinded randomized control prospective for reverse shoulder versus hemiarthroplasty, and they conclude that reverse shoulder placement results in better function, better pain, and lower revision rate. And this is another article sharing the same idea, a third article which concludes that reverse shoulder arthroplasty results in a better clinical outcome and similar complication rate than hemiarthroplasty, while quite a few studies present the same idea. However, in general, in literature, we think that reverse shoulder arthroplasty should be preserved for patients above 70 years of age with a cuff tear or a cuff massive rotator cuff, irreparable tuberosities, or a chronic or neglected fractures. While because we still think that in patients less than 70, in which with a displaced 3 or 4 part fractures, in which you can reconstruct the tuberosities, there is still a role for hemiarthroplasty, especially that with the financial aspect in consideration. We know that the reverse shoulder replacement is like 4 or 5 folds, 3 or 4 or 5 folds the cost of a standard hemiarthroplasty shoulder. Okay, this is her function after 1 year. I wish I could leave her face. She was really happy. Okay, and now I leave the floor for Professor Amr Mustafa to show us, present his case.
Yeah, I think Dr. Amr Said will present.
Amr Said, I'm sorry. Amr Said, sorry, Amr.
Yeah, no problem.
Professor Amr, start sharing.
Okay, thank you, Ashraf. Before I do my presentation, I have a small comment concerning the hemi and reversed arthroplasty. Actually, the success of the hemiarthroplasty is one of the major factors to be successful is the condition of the tuberosities,
yes,
the healing of the tuberosity. If you don't have potential good tuberosity to heal, it will not function. So in this case, reversed shoulder will do much better than hemiarthroplasty.
If I don't mind, the 3 most important factors for successful hemiarthroplasty is the construction of the tuberosities, the proper version, and as well as the proper height. These are the 3 challenges for doing a hemiarthroplasty. Okay.
Okay. Just 1 minute. Thank you for attending and participating in this webinar. My presentation, my case presentation is quite weird. It's a neglected 2-part fracture anterior dislocation of shoulder. It's it's uncommon. It's much less common than neglected posterior dislocation of the shoulder, but it do exist. Our case is male, 28 years old, subjected to road traffic accident.
ايوه انا عندي مشكله في السكرين. هل حتى عنده مشكله؟ مش شايفين السلايدز؟
السكرين مفيش سلايدز باينه.
مفيش سلايدز.
Just 1 minute.
There's a question in the panel: is time important? Well, definitely, literature says that the results of a primary arthroplasty, the results of a primary arthroplasty are better than a secondary arthroplasty. If a primary, literature says if less than 30 days you do an arthroplasty, the results are better when done in a late stage. However, this is very valid for hemiarthroplasty because you are rushing for these tuberosities to heal. But I think in next few years, this needs further literature. I don't think it's been really studied well, that the results of reverse shoulder replacement when done in a later stage might not be, would attain close results to those achieved in a primary setting. That was a question in the question and answer from Muhammad Al-Fakharani.
Sorry, I have some problem.
Yeah.
Do we have some questions to answer?
Yes. Professor Hashim Al-Qada from Jordan is asking about, did the patient have any complaints of pain or limitation of movement when there was failure of the fixation? Yes, she had a limited range of motion and was not satisfied. The role of MRI to assess rotator cuff in a 70-year-old lady is quite important. However, from Mr. Fikri Abu Abdu from Palestine, but it's quite difficult to interpret in the setting of a fracture dislocation. Are you ready, Professor Amr?
I think so.
Please go ahead.
You see my screen?
Not yet.
رابع احنا قادرين نشوف السكرين بتاعت حضرتك دلوقتي. ممكن حضرتك تفتح باوربوينت برزنتيشن؟
Okay, كده تمام.
Now we've got it. Yes, we're in business.
Yes, our case is made 28 years old, subject to road traffic accident, sustained 2 parts fracture dislocation right shoulder and C3 distal radius fracture on the left side. Due to unclear reasons, he didn't sought medical advice except 1 month after the accident. Distal radius was treated by pinning, and the surgeon advised him not to do anything with his right shoulder. And he presented 5 months later with this X-ray. The right shoulder is 2-part fracture dislocation, and the left side for this radius was not doing well. Our concern today is this right shoulder. He had actually no pain in his shoulder, but shoulder fixed in abduction external rotation. But he has pain due to brachial plexus compression, which is obviously is running here beside the head. His CT, as you see, the greater tuberosity was united to the shaft in awkward position with this bony bridge. And as you see, there is a deficiency in the glenoid and deficiency on the head, the Hill-Sachs lesion. The question now is, would you operate or not? Yes or no? You can vote for this. Karim?
شغال الفوتنج كويتشن يا دكتور.
Did you show the results? My question also to the panel, would you operate in this case or not?
Okay.
If you present it, he
Dr.
needs to
Ahmed.
be operated. But the question is what type of operation?
Okay. Dr. Amr, you are listening?
Yes.
Okay. So regarding this case, I think that we should operate, but we have three major concerns. The first concern regarding the viability of the head of the humerus. We at 5 months out of its place, major trauma, high the viability is in question. So we should have more investigations like MRI, so we can assess for the vascularity of the head, and it's viable, so we can see our other concerns regarding how to make reduction because of the time and the chronicity of the injury, the soft tissue surrounding the head of the humerus so tight, and we so it will make so much problem or difficulty regarding reduction. The third concern is how to maintain our reduction after this. So there is all lead to proceed patient, but regarding the age of this patient, we would consider open reduction as priority.
Dr. Ahmed?
Professor Amr?
Yes.
Okay.
Actually, if you try to search about this answer in the literature, you will not found any because these cases are sporadically reported in the literature. So you cannot get any evidence. But in my opinion, for this patient with pain and neuropathic pain, and it is his dominant right upper limb and the other limb is not functioning very good. I prefer to operate. The question is, what will you do? Arthrodesis of the shoulder, open reduction, internal fixation, or you go for arthroplasty, hemi, or reverse? It's also a question for the floor.
Okay.
Dr. Ahmed, what's your opinion?
Okay. For me, I'll go for open. Can you, Professor Amr?
سامعك كده دلوقتي.
Okay. For me, I have open reduction and internal fixation, of course. But as I said before, that I should solve all these three issues that I talked about regarding the method of reduction, the stabilization of the reduction, and how to over tightness of the soft tissue.
Okay. Any of the panel have a different opinion?
I don't think so. That's to proceed, Professor Amr, please.
Okay. As Dr. Ahmed said, we should consider the age of the patient to take the decisions, the age of the patient, the geometry and vascularity of the head, the glenoid condition, shape, deficiency, whatever, and most important, the deltoid function. In my opinion, arthrodesis should be reserved only if there is a marked deformity of the head with absent deltoid or irrecoverable deltoid paralysis in a young active patient. And if the patient is old or fixation cannot be achieved or reduction cannot be achieved, we go for arthroplasty, and I prefer reversed shoulder arthroplasty because it will maintain the reduction. The hemi have many complications in this case. But in this case, with quite reasonable head, and I'm not worried about the vascularity because it's continuous with the shaft. And his deltoid was okay, not greatly atrophied, and it's only 6 months from the injury, so it can recover. I'll go for open reduction and internal fixation. And you should consider after reduction how to maintain the stability of the shoulder. You should reconstruct the glenoid either by bone graft or lateral procedures. And that's what we did. This is a deltopectoral approach. Here is the shoulder, axilla, and this is the head, and this is the lower limb. And as you see, this is a part of the acromion, and this is a musculocutaneous nerve. And we bluntly dissect the plexus away from the head. Here is the musculocutaneous nerve. Then we cut this bony bridge to expose the glenoid, which is here. This here is the glenoid. It was cleared. We cleared it from the soft tissue, and it was, as you see, it's healthy with preserved cartilage. And this is the reduction. Of course, you go through the rotator interval and preserve the subscap and reduce the shoulder. This is a primary reduction. And then we reduce the greater tuberosity to its position and its optimum height. And here's professional fixation first, we checked, and final fixation. And we also do derotation osteotomy of the humerus here to prevent impingement of the head sac lesion and add more freedom of the motion. And finally we do the lateral procedure before closure. And this on the conclusion of the surgery. You can see the shoulder is passively mobile, smoothly. And my message from this case, chronic cases is treatable, are treatable. And treatment should be individualized with careful preoperative planning, and don't burn all the bridges doing arthrodesis or arthroplasty from the start. Thank you.
Thank you, Professor Amr. Anyone from the panel wants to comment or to give questions?
Okay, Professor Hakim, I'd like to he do a Z-plot subscapularis to facilitate the reduction?
Subscap, I'm in favor to keep it because if you plan to do lateral J procedure, you should keep the subscap to get the dynamic function of dynamic stability of the lateral J procedure. However, if you want to release, you can release the superior part only of the subscap, the superior 1/3, no more, to preserve the most of the function of the subscap.
Okay, we can go through some unanswered questions. Role of a coracohumeral ligament for stability of hemiarthroplasty, Ashraf?
I have two questions that I've responded to a lot of questions on the question and answer book, but I wanted to respond to questions. The crociohumeral ligament is usually very difficult to identify. It is there, and it is it blends with the subscapularis tendon, muscle tendon, and we should preserve it with the subscapularis to try to preserve the subscapularis. Should be maintained, and the crociohumeral ligament should be preserved. However, in neglected cases or cases that have been there for a long time, you're not able to. Yes, in neglected cases or cases that, and therefore you're not able to use the subscapularis without release of the crociohumeral ligament. So in fresh cases, you have to strive to maintain it. In chronic cases, you have to release it. Okay.
Okay.
Can I answer another question that I've answered in writing 3-4 times? You're asking about in reverse shoulder replacement. Do you have to? Is it important to reduce the tuberosities and fix them? It is useful to reduce tuberosities and fix them, but it's not fatal not to, like hemiarthroplasty. The most important to be reduced and fixed is the subscapularis, because this is a primary internal rotator of the shoulder.
Mustafa, do you use MRI to assess muscle atrophy?
I think دكتور أشرف اللي هيجاوب على السؤال ده. It's they are asking about arthroplasty, before arthroplasty or not.
No, before,
I will answer.
I don't know.
I'm asking before fixation.
Before fixation, no.
دكتور عبد الحكيم. دكتور عبد الحكيم.
اتفضل يا عمرو.
May I answer this question? Yes, there is a role of MRI to assess muscle atrophy and fatty degeneration, but in chronic cases, not in acute trauma. If you, in chronic cases, if you see complete fatty degeneration of supraspinatus and infraspinatus, which I call grade 4, you'll go for reversed shoulder. But this is not valid for acute trauma, actually. Acute trauma, you cannot get any information from MRI concerning the condition of the rotator cuff. What do you think, Ash?
I agree completely, Professor Ahmed Said. It's very difficult to interpret in the presence of fractures. However, the signal in the supraspinatus might be changed if there's severe muscle atrophy, but you should not. We do not routinely do MRIs to assess the rotator cuff in trauma patients.
Okay, I think we passed 2 hours. If is any one of the panel likes to say final comment, Amr Ali.
No, I
would you like to add anything more?
No,
مفيش عمرو السيد.
هنجيله في الآخر.
For me, this webinar was very full of information. Really, it's very beneficial for me, especially the last case of Dr. Amr Said.
Thank you, Amr. Thank you.
Dr. Hani Morsi. Hani Morsi. Dr. Mustafa Mahmoud. Do you like to add anything?
No, thank you.
Ashraf.
I'd like to conclude if you don't mind.
Yes, please.
You see my screen? Okay. So our take-home message is: what are the treatment options for proximal humeral fractures? They might be non-operative or operative. Operative includes fixation and replacement. Fixation, we've got intramedullary close reduction, percutaneous pinning, open reduction, internal fixation with plating, and intramedullary nails. We did not cover a lot about intramedullary nails because in the region, we don't have the proximal humeral nail available. Replacements might be a hemi, a total, or reverse shoulder replacement. We must remember that non-operative treatment is the main modality of treatment for these fractures, especially in elderly. And this is a Cochrane review, 2016, stating that operative management does not appear to be more effective than non-operative management for fractures of the proximal humerus, particularly in elderly. These fractures, impacted, minimally displaced, must be treated conservatively. These fractures, especially in elderly, with some varus, some comminution, couldn't be very well managed conservatively. And we must not forget the role of conservative treatment in these cases. Systemic reviews have proved that with the wide range of treatment options available, evidence does not support any specific operative treatment choice over the other. Whatever you're comfortable and you probably can be able to do that. But the strategy would be always to reduce the dislocation, reduce the fragments, the neck shaft angle, the calcar, reduce the tuberosities, and fix those tuberosities to the phyllos plate, as you can see in these sutures. And you have to support and fill the comminution section, as Mustafa showed us, and fix to good bone. Better if using angular stable fixation and using calcar screws like those here. Okay, so that's our open reduction internal fixation strategy. Accurate reduction is mandatory, and it's much more important on your choice of implant. Reduction, the success of the fixation depends more on reduction rather than the stability of the implant you're using. And last but not least, a systematic review covering effectiveness, safety, and economy of treatment of humeral fractures in the elderly, 2018, by my dear friend Carl Ekholm, states that surgical treatment of moderately displaced proximal humeral fractures in elderly does not seem to yield any benefit compared to less costly non-surgical operative treatment. And this should be our concluding statement to other attendees. I'd like to thank our close to 400 participants who attended this session and the close to 300 that have stuck with us throughout these 2 hours. And thank you very much, everybody. I'd like to thank the panel, Professor Abdelhakim, and the moderator, Professor Hakim Abdullah, Professor Hani Morsi, Professor Amr Mustafa Ali, Professor Ahmed Sadiq Fathi, and I would like to my co-presenters who added a lot to this session, Professor Ahmed Said and Professor Mustafa Mahmoud, my dear colleagues. And we thank you all for attending the first online activity for the Egyptian Society of Hand Microsurgery, and we hope to see you all in our next upcoming meetings. You want to conclude something, Professor Abdelhakim?
No, I just want to pass the final word to our President, Mustafa Mahmoud.
Thank you very much, Dr. Hakim. I enjoyed very much your moderation, and I enjoyed every case in this presentation. Thank you very much, all the panel, and my dear friend, Dr. Ashraf Muharram and Dr. Amr Said. Thank you all.
Looking forward to coming meeting.
Thank you all.
Yeah, thank you.
Thank you.
Thank you.
Thank
Good night.
Bye.